welcome back to our high-yield series on tuberculosis. So in part 1, we really laid the groundwork, right? We covered the basics and how the disease develops. Today, we're jumping right into the clinical side of things, how you spot TB, how you prove it's there, and most importantly, how you treat it. This is all about getting you ready to ace those exams.
Okay, so here's our game plan for today. We're going to start with reactivation, what happens when that dormant TB wakes up. Then we'll move on to the classic clinical features you've just got to recognize. After that, it's all about the lab work, the real detective stuff, from a basic smear all the way to advanced molecular tests. And we'll wrap up with the battle plan, the treatment regimens, and the huge challenge of drug resistance. Let's get into it.
First up, reactivation. Now, remember from our last chat, after that initial infection, the TB bacteria can just hang out, totally dormant for years, maybe even a lifetime. So we really need to understand what makes this sleeping giant wake up and start causing trouble all over again. Now have a look at this. This is your classic textbook clinical scenario. An older patient with a cough that won't go away, fever, night sweats, and they're losing weight. You're going to see this pattern again and again, I promise you, in your exams and on the wards. The moment you see this, your brain should be screaming reactivation or secondary tuberculosis.
So for your exams, this is absolutely crucial, knowing the difference between primary and secondary TB. This slide lays it out perfectly. Primary TB, that's the first time you get infected, usually as a kid. It hits the middle or lower parts of the lungs and often just heals on its own. But secondary, or reactivation TB, that's what we typically see in adults. It loves the upper lobes of the lungs because there's so much oxygen there. And that's where you get that classic cavity formation on an X-ray. Big takeaway? Primary often heals. Secondary almost never does without treatment.
All right, let's move on to the clinical features. These are the telltale signs that let you start building a case for TB in your head, long before you get any lab results back. These are the absolute classics you've got to burn into your memory. A cough with sputum for more than 2 weeks, that textbook evening rise in fever, drenching night sweats, and weight loss that they just can't explain. When a patient walks in with this mix of symptoms, you know what they're called under the national guidelines, a presumptive TB case. And that one term kicks off the entire diagnostic process. And boom, this CT scan is a perfect picture of what we were just talking about. This is exactly what we're looking for in reactivation TB. You see that arrow? It's pointing to a cavity, a literal hole, in the upper lobe of the lung. This happens because the reactivated bacteria are just thriving in all that oxygen, destroying the lung tissue. Now, it is so important to remember that TB is not just a lung disease. It can get into the bloodstream and set up shop pretty much anywhere. We call this extrapulmonary TB, or EPTB. The most common spot, the lymph nodes. That's tuberculous lymphadenitis. But you always have to keep in the back of your mind that it can hit the spine, causing Pott's disease, or even the brain, leading to a deadly meningitis. Okay, so you have your suspicions. Now what? How do we prove it? This is where the microbiology lab comes in. It's pure detective work. Let's walk through the diagnostic pathway, step by step, from the old school techniques to the new game changers. First up, and the fastest test, is microscopy. On the left, that's the classic ziehl-neelson, or ZN stain. You can see those little red, beaded, acid-fast bacilli. But on the right, that's the fluorescent stain. The bacteria just light up, glowing a brilliant yellow, which makes them way easier and faster to find. And because it's more sensitive, fluorescent microscopy is actually the recommended way to screen for TB under the national program. Okay, pay very close attention here. This grading system from the RNTCP is super high yield for your practical exams. You've got to know how to grade a smear, from scanty all the way up to 3+. And it's not just for writing a report. This grade tells you about the patient's bacillary load, basically how infectious they are, and it helps us track how well the treatment is working. Now this is where things get really interesting. Look at the evolution here. On the left, you've got the old school gold standard, the Lowenstein Jensen, or LJ medium. Yeah, it works, but it is painfully slow. We're talking 6 to 8 times weeks to see anything grow. Then look to the right. That's the game changer, the GeneXpert system. It's a type of test called CBNAAT. It's molecular. It finds the bacterial DNA, and this is huge. It also checks for resistance to a key drug, rifampicin, and it does all of this in just 2 hours. It has totally revolutionized TB diagnosis. All right, for your practicals and your Viva, these mnemonics are pure gold. To remember what's in an LJ medium, just think game. Malachite green, asparagine, mineral salts, and egg. Easy, right? And to describe what the TB colonies look like on it, just remember this phrase: rough, tough, and buff-colored colonies.
Simple, but it works every time. Think of this flowchart as your official roadmap for diagnosing TB. You start with your presumptive case, you do a smear, you get a chest x-ray. If that smear is positive, great, you have a confirmed case. But look at where CBNAAT fits in. For any case where the smear is negative, but you're still really suspicious because of the x-ray or the symptoms, you go straight to this molecular test. This is how we find those tricky cases that microscopy just can't catch. So, we have a diagnosis. What's our battle plan? Let's break down the treatment strategy. It's a pretty standard combination of drugs and a set timeline, but we also have to deal with the massive growing problem of drug resistance. The absolute cornerstone of TB treatment is this 4-drug combo. The drugs are isoniazid, rifampicin, pyrazinamide, and ethambutol. You can remember them with the acronym HRZE, or the one I think is easier, RIPE. You have to commit this to memory. Okay, so the standard treatment for regular drug-susceptible TB is a 6-month course, and we split it into 2 phases. First up is the 2-month intensive phase. Think of this as an all-out assault. You hit the fast-growing bacteria hard with all 4 drugs, HRZE. That's followed by a 4-month continuation phase. Here, we drop one of the drugs and continue with just HRE to basically mop up any of the slow-growing or sleeping bacteria and make sure the disease doesn't come back. Now, let's clearly define the enemy here, drug resistance. The simplest form is called monoresistance. It's exactly what it sounds like. The bacteria are resistant to just one of the first-line drugs. Straightforward. Moving up a level, we've got polyresistance. This means the TB is resistant to more than one of the first-line drugs. But, and this is the key part, it's not resistant to both isoniazid and rifampicin at the same time. And that brings us to MDR TB, or multi-drug resistant TB. This is a huge public health problem, and you absolutely, positively have to know this definition for your exams. It is specifically defined as resistance to at least both isoniazid and rifampicin, our 2 most powerful drugs. And then there's this, the most dangerous common form, XDR TB, or extensively drug-resistant TB. This is when you have MDR TB, but on top of that, you also have resistance to 2 more classes of drugs, any of the fluoroquinolones, and at least one of the main second-line injectable drugs. You can imagine this makes treatment incredibly difficult, really long, and often very toxic for the patient. This algorithm really shows how everything comes together. Today, we do something called universal drug susceptibility testing. Basically, every patient diagnosed with TB gets tested for at least rifampicin resistance right at the very beginning, usually with that initial GeneXpert test. The result of that one test, is it rifampicin sensitive or resistant, is like a fork in the road. It determines the entire treatment journey for that patient. All right, let's wrap this up. Here are the most critical, high-yield points for your exams. First, know how to tell primary and secondary TB apart. Think location in the lung and cavities. Second, you have to know the RN-TCP grading for sputum smears. Third, understand that huge shift from slow culture to rapid molecular tests like CBNAAT. Fourth, memorize those definitions of MDR and XDR TB. No excuses. And finally, know the standard 6-month HRZE regimen and its 2 phases. If you master these 5 points, you'll be in great shape. And that leaves us with a pretty heavy question for the future, doesn't it? The fight against this ancient disease is far from over, especially with these super resistant bugs on the rise. Mastering this material isn't just about passing an exam. It's about understanding one of the biggest challenges in global health. And it's your first step to becoming part of the solution. Thanks for joining me.